What is the management of major trauma and multiple injury? The method of management of this patient is ATLS protocol. What is ATLS protocol? Advanced Trauma Life Support Protocol, ATLS. First of all, primary survey and resuscitation. The primary survey and resuscitation, always remember A, B, C, D, E. A is airway, B, breathing, C, circulation, D, disability, E, exposure and environment. Let's start this primary survey and resuscitation. First of all, we should notice that the primary survey and resuscitation should start at the site and at the time of the accident by well-trained ambulance team. And this primary survey and resuscitation continue until the victim reach the emergency department in the hospital. Let us discuss first the A. A is airway and control of cervical movement. Why this is the first step? Why we should start with airway and cervical control? Because one of the commonest cause of death immediately after trauma is airway obstruction and unstable fracture cervical vertebrae leading to injury of the upper part of the spinal cord. Therefore, to avoid these two main causes of this, we should start by key patent airway and control of cervical movement in concomitant with each other. Key patent airway in concomitant with control of movement of cervical vertebrae. First of all, we should evaluate the airway and protect the airway. How to evaluate the airway? In general, speak to the patient. If the patient is capable of normal, unstrained speech, this means that the airway is patent. All patients should receive oxygen by mask and keep patent airway and clear airway. How? What is the main causes of airway obstruction? The commonest cause for airway obstruction is vomitus, blood, secretion, or foreign body in the respiratory passage. We should clear all these structures: blood, vomitus, secretions, foreign body. How to clear this? By this, which is by finger sweeping. Clear the airway by your finger. sure with glove finger. Or if available, we can suck all blood, vomitus, secretions, etc. by a rigid sucker. Also, one of the commonest causes for airway obstruction, especially in uncomatose patient, is falling back of the tongue. This is a patient lie flat. When the patient lie flat and unconscious, the tongue by its weight may drop backward. This shows the normal, the tongue in place, and the airway, oral airway and the nasal airway is patent, and the air passes freely to the larynx, trachea, and the remaining part of the respiratory passage. If the tongue fall backward and the posterior one third of the tongue come in contact with the posterior wall of the pharynx, this leads to complete respiratory obstruction. Therefore, we should pull the tongue forward. How to pull the tongue forward? By this muscle. What is this muscle? This muscle arises from the inner aspect of the symphysis mentis from tubercles called genial tubercles. And from the genial tubercle, this muscle passes to the tongue. From genial tubercle to tongue, therefore, this muscle is called genioglossus muscle. If you lift the chin of the patient forward, you pull the genioglossus forward, you pull the tongue forward, leading to patent airway. But this is dangerous because lifting of the chin need to tilt the head. Tilt the head is dangerous if there is suspicious of injury of cervical vertebrae. This may lead to spinal cord injury. If there is suspicious of injury of cervical vertebra, this is better. What is this? This is jaw thrust. Hold the mandible, the lower jaw, and pull the mandible forward. If you pull the mandible forward, you pull the chin or the symphysis mentis forward, you push the genioglossus forward, pushing the tongue forward, leading to patent airway. Therefore, to pull the tongue forward, chin lift and jaw thrust to prevent falling back of the tongue. After we ensure clear patent airway, before we leave this point, you should notice that the commonest cause for upper airway obstruction is falling back of the tongue, inhalation of blood, vomitus, secretions, or teeth, inhalation of teeth or denture, and soft tissue edema if there is injury in the face. After we keep patent airway and clear the airway, protect the airway. How to protect the airway? First of all, in the site of the accident, we can put nasopharyngeal or oropharyngeal airway. This is simply a tube introduced from the nose to the pharynx. Therefore, it's called nasopharyngeal tube. And if you perform this maneuver, the tube is narrow because the nasal opening is small. you introduce a narrow nasopharyngeal tube. It is better. The oral cavity is wide. You can introduce a larger tube called oropharyngeal airway. The oropharyngeal airway prevent falling back of the tongue and occlude the airway to prevent inhalation of blood, vomitus, or secretion. Also, we can introduce tracheal airway or tracheal intubation. What is the indication for tracheal intubation? Apnea, maxillofacial trauma, inhalation of blood or vomitus, injury of the airway, closed head injury. Why in closed head injury we use the endotracheal tube or tracheal intubation? To allow mechanical ventilator and to allow hyperventilation. Hyperventilation leading to decreased carbon dioxide tension in the blood, and decreased carbon dioxide tension in the blood leading to decreased intracranial pressure. Therefore, if you want to use mechanical ventilator or any closed head injury to allow hyperventilation to decrease intracranial pressure, any airway injury, injury of larynx or injury of the trachea, and we want to introduce the air directly to the lung, we use tracheal intubation, or also called endotracheal intubation. What is the method of endotracheal intubation? Like oropharyngeal and nasopharyngeal airway, we introduce a tube either from the nasal cavity, and this is called nasotracheal intubation, or we introduce a tube from the oral cavity to the trachea, and this is called orotracheal intubation. And orotracheal intubation is better because we use a larger tube than the nasotracheal intubation. Nasotracheal intubation is safe, more safer if there is cervical injury is suspected, because technically to introduce orotracheal tube we should extend the head, and in this extension there is fear of movement of unstable cervical fracture leading to spinal cord injury. Therefore, nasotracheal tube is safer in cervical spine fracture injury. During emergency also we can try cricothyroidotomy. What is cricothyroidotomy? This is the thyroid cartilage, Adam's apple. Below the thyroid cartilage there is a cricoid cartilage, and between the cricoid and thyroid cartilage there is a membrane called the cricothyroid membrane. We can do surgical incision in the middle line of the skin and the cricothyroid membrane and introduce a tube like this. This is called surgical cricothyroidotomy. Or we can introduce a large bore needle into the cricothyroid membrane, and this is called percutaneous needle thyroidotomy, cricothyroidotomy. Percutaneous needle cricothyroidotomy. What is the indication of cricothyroidotomy, surgical or percutaneous needle cricothyroidotomy? It is a temporary measure done for emergency in urgent upper airway obstruction to introduce air into the larynx directly to pass the upper airway obstruction in the inlet of the larynx, because the common site for upper airway obstruction is the inlet of the larynx. And if you introduce air below the inlet of the larynx, you bypass the obstruction in the airway. What is the contraindication of cricothyroidotomy? Children below 12 years. Why? Because the cricothyroid membrane is very narrow. And the technique is nearly impossible. Also, cricothyroidotomy is contraindicated if there is tracheal injury. If there is tracheal injury, the cause of obstruction below the cricothyroid membrane. Therefore, if you try to introduce air through the cricothyroid membrane, the air will facing the obstruction below this level. And sure, tracheal intubation is the best. To know how to do cricothyroidotomy and the previous techniques, please you can see these videos in the YouTube. We all know a technique called tracheostomy. Tracheostomy nowadays is not done in emergency. It is done an elective operation if respiratory obstruction is prolonged for more than 10 days. We do tracheostomy. And sure, in the previous 10 days, we use orotracheal or nasotracheal tube. After we take how to keep patent airway and the method is to introduce air in the respiratory passage in this accident, in concomitant with patent airway, we should control cervical spine. How to control cervical spine? Immediately once you see the patient after the accident, manual immobilization of the head and the cervical spine until we introduce this rigid collar and put on the sides of the head these bags to support the sides of the head, and apply adhesive tape across the head, across the forehead to fix the head. Therefore, first of all, once the trauma occurs, manual fixation of the head until rigid collar is applied. In addition, support the sides of the head by 2 bags and apply adhesive tape across the forehead to fix the forehead. Cervical spine injury is suspected, and unstable cervical spine is suspected by what? Clinical examination show deformity or tenderness in the cervical region. Or if you see maxillofacial injury. If there is maxillofacial injury, this means that there is head trauma. And head trauma sure affect the cervical vertebrae. Or trauma, any evidence of trauma above the clavicle. Wound here, abrasion here. Any trauma above the clavicle means injury in the head and the neck and the possibility of injury of cervical spine. Also, cervical spine injury is suspected in multi-system trauma and unconsciousness. In the hospital, immediate radiological evaluation. Immediate radiological evaluation of this patient in 3 views: anteroposterior, lateral, and odontoid view. Odontoid through the open mouth to see the first 2 cervical vertebrae, atlas and axis. This is called odontoid view. This is the first step, which is the primary survey, which starts by airway and stabilization of cervical spine. We will continue in the next video. Thank you for good listening and good luck.